Hello, I'm Dr. Jim Epstein, and this is Best of the Day from the 2013 combined meeting of ECHO, ESMO, and ESTRO held in Amsterdam, the Netherlands this year. And so we're finishing up the meeting. Today is the final day, a few minor sessions tomorrow morning, but most people are hoping to head home tomorrow morning. But joining me this evening to talk about some of the data presented in genitourinary cancers, prostate, renal cell, and even urothelial cancers is Dr. David Quinn from the University of Southern California. You'll notice that David does not have a Southern California accent, so don't be misled by that. So David, welcome. Thanks so much for coming.
It's always a pleasure.
Well, it's always good to have a chance to sit down and talk to you about GU malignancies and get your perspectives on things. So there was a number of interesting presentations this year, and let's begin with prostate cancer. Enzalutamide is now on the market, this androgen receptor inhibitor, that it was a significant advance over the first generation agents, and it's been approved for patients who are castrate resistant. But there was a protocol presented in the results of a study looking at enzalutamide in hormone-naive patients, the sort of patients for whom you would normally just use an LHRH agonist.
Correct.
And so how did enzalutamide look in this population?
It actually looked fairly good. The PSA waterfall plot was impressive, with more than 90% of patients having a very significant PSA response, documented RECIST response, so shrinkage of disease. The trial was interesting. It was a combination of patients that were M0, no metastases, and M1, but none of them had had prior androgen deprivation, so no LHRH. And the endpoint was with about 68 patients, was how they did after about 6 months of therapy. And so we've had those endpoints reported, and of course very impressive response data, especially with a single agent, but also with some caveats. Significant rate of gynecomastia and breast pain, probably not as high as we saw previously with bicalutamide, especially when it was given in the triple dose. So we have therapeutic activity. The issue is going to be what's going on with the side effects. Some interesting things were that there was no decrement in bone mineral density. There was no adverse effect on lipids, although there was an increase in the insulin level in patients, raising the issue as to whether there may be some effect on metabolism that could contribute to diabetes or cardiovascular disease. But overall, it looked impressive.
So with blocking the androgen receptor, you would expect that there would be a feedback increase in testosterone. And I think Eleni Efstasou from MD Anderson also looked at the possibility of combining enzalutamide with abiraterone acetate so that you would abrogate those. How does that data look, and do you think that that is a reasonable strategy?
Well, I think we got our first look at that here. And so this was a study done at MD Anderson, where they had previously looked in individual trials at enzalutamide and abiraterone separately, and had shown that if you gave enzalutamide, you had upregulation of metabolizing enzymes, so that you got more production of androgen. If you gave an enzyme inhibitor such as abiraterone, you got upregulation of androgen receptor kinetics. And so the idea was putting them together would suppress that. And this is the first of this data that we've seen. It's only just finished accrual. It looks like the combination is tolerable, so there were no particular safety issues. Some patients did get increased hot flashes on top of their LHRH therapy, but there were no particular issues with toxicity. And these patients all got their bone marrow biopsied. So there were attempts made in every patient to biopsy their cancer. And when they were biopsying the cancer, they also sampled the bone marrow milieu to look at what was going on with the metabolizing enzymes, the hydrolases, and also the androgen receptor platform, and also dihydrotestosterone.
Right.
And they were able to suppress the compensatory responses that we saw in the previous evaluation of the individual agents. Now, this is not ready for prime time in terms of combination. We're going to have to get further follow-up
Right.
on progression-free survival. Surrogate readouts like PSA looked good with major suppression in this group of patients with metastatic disease. But we're going to have to look at it longitudinally. There are follow-up studies planned where we're going to be looking at the addition of enzalutamide or enzalutamide and abiraterone in an alliance study that will be going forward in North America, and we expect that to start in 2014. So we will be following up on this, and I think the main message coming out of what we saw at this meeting is that it looks like it's safe. The question is whether the combination is going to be better than an individual therapy.
Right. So it conceptually, it sounds very interesting. We just need larger numbers and longer follow-up.
Yeah, I think we need to test it more. We need to work out whether the combination is going to be better than the sequential therapy, which is essentially what we do now. And I think that's an interesting question. Of course, when you give drugs in combination, you've got the toxicity and also the cost of the two drugs at the same time. When you give them in sequence, you may lose some efficacy after you give the first drug, and even though they have different mechanisms of action, you do tend to lose some efficacy with the second drug. And we're still working out this combination sequencing question in prostate cancer with all the new therapies we've had in the last 3 years.
So will the alliance trial be combination versus sequence, or is it just combination versus single agent?
It's combination versus single agent at this stage. We have issues with doing sequencing trials in that if you have sequencing in one arm and not in the other, which intrinsically is what we have here, you can get a significant drop-off. So when people are meant to go across to the other drug, it doesn't happen.
It doesn't
and
always happen.
You lose power. And I think we were looking at a primary endpoint of disease or progression-free survival there initially, and then looking at overall survival to see whether there'd be a benefit. So there are other studies planned to look at the sequence one way and another, and also the combination. That probably won't go forward in North America. It will either be an international study or done in Europe or Australia.
Very good. Well, I know there are other CYP17 inhibitors in the pipeline, just as there are other androgen receptor inhibitors in the pipeline. ARN-509, I think, is one of them, but there was a new one, new to me anyway, presented at this year's meeting, ODM-201. How does this novel agent differ from enzalutamide and ARN-509? Is it chemically different? How does the efficacy look?
Well, in actual fact, it has a different structure to the prior drugs we've looked at. So sequentially, we've had drugs like flutamide and baclutamide, and in developing enzalutamide, Charles Sawyers and co. were looking to develop a drug that was not was essentially active in resistant cells, and they developed a series of models to do that. ARN-509 is a similar structure, some would say an analog, and it's been developed. This is a different structure and was developed by a different group, and has some interesting activity. It's the first time we've had it presented, so it was significant, and based on the best readout that we've got at this early stage, PSA responses looked impressive, and they looked impressive almost regardless of the prior therapy that the patients had had. What we had presented was a phase 1 study, so we had some escalation issues as they moved up. They didn't really hit a maximal tolerable dose or a DLT. So the toxicity issues were not terribly significant. But at the top dose, the PSA responses were very significant, and there were some toxicities, but it didn't look to be limiting at all. So it's an interesting compound, and essentially I think we're working on our androgen receptor biology to try and improve our therapeutics in that area. And I'll be interested to see how things evolve with enzalutamide, which is in the market, ARN 509, and now ODM 201. And I'm sure we're going to see some other drugs as well that will compete. They may be better or equivalent or better tolerated. I think that remains to be seen.
So does ODM 201 have greater affinity for the androgen receptor than enzalutamide does? Does it have other potentially beneficial effects?
So in the lab, it's got greater affinity, but whether that greater affinity on a milligram per milligram or an equivalent dosage situation is going to translate to being better.
Clinically, right.
Yeah, you've also got the other issues of interaction with the androgen receptor, which we know gets mutated, and splice variants occur that can alter your response to these drugs. And so Charles Sawyers gave a very eloquent presentation at this year's ASCO at the plenary session on what happened with the various agents and how the sensitivity, not just to the different agents, but different hormones, even glucocorticoids, was regulated by these mutational variations in the androgen receptor. So we may be tailoring the use of these drugs based on that, but at the moment that's science fiction, and we're going to have to really work on the markers that tell us about that. But this is a new age. We've got much better drugs.
Very good. Well, the standard androgen deprivation therapy for a number of years now has been LHRH agonist plus a short course of androgen receptor blockade. But the LHRH agonists like Lupron and Zoladex have this problem with elevated androgen levels initially. There are other drugs that are LHRH antagonists that avoid that, drugs like the Degarelix and Abiraterone. They never seem to have caught on nearly that well. And so there was a presentation at this year's meeting, really kind of a meta-analysis of multiple trials comparing Degarelix with LHRH agonist, and how did it look? How did it compare?
Well, Degarelix in terms of efficacy looked slightly better in this meta-analysis. Now, meta-analyses are what you put in is what you get out, and there was a significant heterogeneity of the populations that went into the meta-analysis. But that said, it looked like the progression-free survival, PSA kinetics, and with a trend to overall survival favoured Degarelix, the antagonist drug, over the traditional agonists like Leuprolide and Gaserelin. So from that perspective, that was interesting because I, like a lot of other people, have been saying, well, why would we give a man a monthly injection when he could have 3 or 6 or 12 monthly injections of the, in quotes, older therapy? And why would we put him through coming back and having to come to the clinic, and also through some interesting side effects? So Degarelix tends to produce this sort of induration or welt-like area at the injection site in patients in about 25% of cases. And that's quite off-putting for some of them. Some of them actually asked to have lidocaine given with the thing, so that they sort of, or bupivacaine or something that's a bit longer acting. So I think what we're seeing here is a principle that the therapy may be better. And I think we're going to have to look at this a little more. Would it sway me towards giving Degarelix to every patient? Actually not. But the next time I start a patient and I need to start this therapy, I'm going to talk to them about Degarelix. We have it on our formulary and say, look, there may be some evidence that it's slightly better. there are some side effects. And so this brings drugs like degarelix into the equation for me to discuss with my patient. I think my standard practice is still going to be the LH-RH agonist, plus usually some glutamide for a month. Some of us now treat out to about 6 or 7 months because the PSA nadir is prognostic with that combination. And so, just where we go with degarelix now, I think we're ready maybe to have some trials and some comparative effectiveness work.
What about bone mineral density, which is a problem with the LH-RH agonist, and cardiovascular side effects and things like this? Are they pretty comparable with the two agents?
They're relatively similar. There'd been a question as to whether quality of life varied, a question with a more rapid drop in testosterone and dihydrotestosterone with abiraterone and degarelix as to whether you'd get more bone mineral density issues. Now, in terms of the studies we've done, as far as they've been tracked, there doesn't appear to be a great deal of difference between the two and those side effects. But I think I'd like to see some more data with those listed as endpoints. Some of the early degarelix studies were not well defined, and there were evaluations of things like hot flashes retrospectively that always worry me. I think that the activity is obviously enough to be equivalent in the eyes of the FDA and other agencies. I think now, if there may be a slight advantage, we need to start looking at that. One meta-analysis does not make the summer.
Right.
And I think I'd like to see some more data.
Right, very good. In most of these trials, whether it's early disease or metastatic castrate resistant, PSA response is one of the things that is usually followed, and now a number of the trials are looking at radiographic progression-free survival. But Howard Shear had a presentation today looking at sort of a composite of biomarkers that included the circulating tumor cells. And we've heard a lot of presentations about circulating tumor cells in breast cancer and prostate cancer and other diseases. Is this for real? Is this something that we should be enumerating in our patients with metastatic castrate-resistant prostate cancer, especially if they're beginning a novel therapy and we want to tell in a month whether or not they're likely to respond?
Well, I think after this meeting, the answer may be yes. So what had happened previously with PSA kinetics and a fall in PSA is that we'd spent a lot of time at the Southwest Oncology Group trying to validate and see whether it was a surrogate marker, because if we have a surrogate marker, it makes our drug development a lot easier, and it also makes clinical decision making a lot easier, and it's something you can test. PSA failed narrowly to make that in patients treated with docetaxel-based chemotherapy versus mitoxantrone in the SWOG 9916 study. And so we've been looking for better markers. Circulating tumour cells came along, and we know that CTC's falling after the first cycle, good thing. CTC's going up, not a good thing. The issue was, can that really make a difference? So what Howard Shear presented was data from the abiraterone 301 study, where they took apart all of the markers that traditionally predict, including PSA, ECOG status, albumin, hemoglobin, lactate dehydrogenase, and they put it together with CTCs and they did an analysis. Now that data had already been presented, but what Howard Shear presented at this meeting was what we call a Prentice's criteria evaluation. And for Prentice's criteria, you need to have a trial where there's a difference, and there was a significant difference in that particular study in the favour of abiraterone and prednisone versus prednisone. And then there are several other surrogacies that you need to go through. And in actual fact, CTCs met all of those, and then at the final assessment, the CTC change is meant to be independent of the therapeutic arm, so abiraterone, prednisone versus prednisone. And this is the first time that we've seen that it was. So that's actually pretty exciting data, and I think for me makes me scientifically satisfied. And we've been working with CTCs for some time. We have Southwest Oncology Group data that we presented with docetaxel and atrasentan showing very strong surrogacy after the first cycle for outcome. And we got an additional dose of that at this meeting where Nicholas Vogelsang presented the mainsail data, which was a study based also around docetaxel and lenalidomide, which was a negative study. But in that study, he demonstrated that what we saw in the SWOG chemotherapy group and what had been published before in a non-trial group in terms of the kinetics rang true. So do we send our oncologists out next week to do a CTC level after 3 or 4 weeks of docetaxel or abiraterone? Well, you might want to do it. It's costly, and I think you need to derive a benefit from it. And really what we've been doing till now is, if we need a game breaker, we've been using the CTC to help. If we're not sure what's going on with the response, how the patient's doing, it's an additional factor. I think we're now ready for some trials where we look at people in that first month of therapy. And remember, the average number of docetaxel cycles that we give with chemotherapy that can be quite toxic is 8 to 10. Well, if you know a patient's not going to do well at the beginning, there may be option to switch. And we've got some studies coming that are going to help us with that. The first TANA study will look at first use of docetaxel chemotherapy versus cabazitaxel chemotherapy to determine whether there's a difference between the two, both in terms of efficacy and tolerability. Now, it'd be nice to have some CTC data that could tell us after one cycle of either, if there's truly a choice, that we might be better switching to the other one.
So if the circulating tumor cells rise, does that mean the patient is not going to get a response after several more cycles, or if they drop, are they definitely going to get a response?
Well, it's actually very predictive, and in the two groups you mentioned, if they go up, that patient is very likely at 12 weeks to have progression. Based on, and that's non-PSA progression, so it's actually scans showing new disease. It also, if it goes down, then they're very likely to, in our experience, make it through to 10 or 12 cycles of docetaxel. There are a group in the middle, and where the CTCs don't change. And what the Prentice criteria evaluation, at least in this set, says is that overall, the CTC indicator is actually very strong. We're going to have some more data, hopefully from this set, looking at circulating tumour cell kinetics, because this analysis was largely based on the baseline, but did get into some changes. So I think we're going to get some more data, and we need to think about how we're going to incorporate that into practice, and we're going to have some biomarker trials to test some of these things and educate ourselves about what a switch could be. And the good thing in prostate cancer is we have new therapeutics where we can line them up, and we have to make choices. And if we've got something that can help us make that choice, that will very likely be cost effective.
Very good. Let's move on to renal cell. It's an area that's been very exciting in the last 4 or 5 years with all the VEGF-directed therapies and mTOR-directed therapies. It seems like in community practice, sunitinib and to some extent pazopanib have been the first-line agents for patients who are in the lower intermediate risk group by Memorial Sloan Kettering criteria and other criteria. But when it comes to second line and third line, there have been a number of trials trying to determine if a switch to one of the novel agents, sorafenib has kind of become the backup drug. If you have sunitinib or pazopanib first, you're either going to get everolimus second, maybe sorafenib third, or vice versa. So there have been a number of trials to see whether or not that can be improved.
Right.
And there was a presentation again this year. Bob Motzer presented the GOLD trial looking at dovitinib, which is a FGFR inhibitor, you know, a marker that is overexpressed and thought to be a significant factor in resistant disease. Who's the boss? Is sorafenib still in charge, or is dovitinib going to replace it?
Well, dovitinib is not going to get licensed on this data, and it was very disappointing that a novel agent that is actually very well tolerated came forward and cannot displace sorafenib, which has been around for some years, and I think we know how to use very well. So both the progression-free survival and overall survival were negative, not significantly in favour of davitinib. Toxicity was reasonable. There were different toxicities. Hand-foot skin reaction with davitinib didn't appear to be at all common. Whereas diarrhea seemed to be more common with davitinib than sorafenib. So we're not going to get a new agent. And I think what this study did, it was a very well done study, and the patients had to have had in sequence a VEGF inhibitor and then an mTOR. So at least one set of standard of care of the first-line therapy and an mTOR in the second. Some people would argue that VEGF, so following perhaps sunitinib with axitinib is a standard. In many parts of the world it's still sunitinib, sorafenib. And I think there's a benefit to sequential therapy. In the third line, the patients now had a survival of 10 or 11 months, which was actually good.
Pretty good, yeah.
But sorafenib, as it has done in now 4 or 5 trials in a row, performed much better than expected. And so there was no difference. And my reflection on this was disappointment. I think it was a good study. But there are some biomarker evaluations that are going to occur on tissue and some liquid changes. And hopefully that can inform us. If we see that patients that were overexpressing or had some mutation to FGF in their original tissue, and the mutation was what we'd found in bladder cancer to suggest increased activity of this drug, not necessarily the same in kidney cancer, where we were looking at at FGF pathway as a resistance factor brought on by prior therapy and made more important. So an epigenetic rather than a genetic change. But if there is a suggestion from the tissue that we can select patients that should get an FGF inhibitor, we may go back to this. But I suspect that unless there's something very striking, we develop our first marker in renal cell cancer out of this, then I think that davitinib is not going to go forward in renal cancer.
Well, these patients had obviously already been exposed to a VEGFR inhibitor or bevacizumab and everolimus or temsirolimus, so they were pretty much down the line. But it seems like there is such an effort to try to find another class of drugs that is not VEGFR or mTOR directed that will produce efficacy. And c-Met or FGFR or whatever, nothing is working out so far.
Well, I think it's a matter of how we test it and who we select. And I think if this had have got up as a third line, I think it would have been very interesting. And it's very important that we do these studies to benchmark. Now, if we look at c-Met, FGF, angiopoietin, a series of other things, we think they're important for resistance. But we don't know that, and proving it clinically can be kind of difficult. It may be that when we go back and look at the genetic makeup, which we know is heterogeneous in renal cell cancer, that there are some things that tell us what therapy to give. And I think that we're going to have to put that together. So we're moving towards a biomarker trial in renal cell cancer.
Right.
The question is, what should that be? And we've grappled with this a little bit in the intergroup mechanism. And I think we may actually be going back to look at factors like lactate dehydrogenase, some things that are surrogates for C-reactive protein, interleukin 6 and interleukin 8, to see whether they can predict what therapies we should give first and in sequence. The interesting thing is that it's the paradigm in a lot of cancers. We see it in colorectal cancer. The more therapies the patient can have, the better they do. And so we did have some data presented from a huge database from one of the companies, Pfizer, who's done a lot of trials over the years. And it was very interesting. They had VEGF-related therapy, they had mTOR, and they had immunotherapy, mainly interferon. And they demonstrated that the level of response almost no matter what sort of therapy you got, predicted your subsequent overall survival. And we'll have to work on that a little more. If we could work out who might have a good response to immunotherapy, that might be great. And obviously we have some novel immunotherapies coming, particularly the checkpoint inhibitors.
Very interesting. I've always wondered whether for the patients who get 2, 3, 4 lines of therapy, is it because of the therapy they got, or is it because of the nature of their disease that they stayed around long enough to get those therapies?
Or are they just stronger and they can survive longer
and
and they'll put up with the side effects and get through it better?
So in some of the earlier trials with the mTOR inhibitors, one of the groups that seemed to perhaps derive significant benefit were the papillary renal cell carcinomas. Now at this year's meeting, there was a report of everolimus strictly in papillary renal cell carcinoma. Did that hold up as a significant therapeutic agent in that small group of patients?
There are selected patients with papillary renal cell cancer that respond very well to mTOR inhibitors, but really it wasn't borne out in the trial. And so a lot of us were kind of confused with that. And one of the issues is I think we need a comparator to look at. And we have a variety of agents that seem to have activity in certain papillary patients. So the VEGF TKIs seem to be active. c-MET seems to be an important target. And in addition, the insulin-like growth factor receptor pathway and EGF seem to be important. So we have a spectrum of trials going on, and in a given practice, the non-clear cell make up about maybe 20 to 25% of the patients that you see, and most of them are papillary or papillary. And I think we're going to be looking at some trials. And we had some discussion after Raptor to say, well, you know, it clearly worked well in some patients, but we didn't think it differentiated quite well enough. And then there's discussion from the NCI of wanting to do some studies with a variety of MET inhibitors that we now have added to a backbone of a VEGF inhibitor, and perhaps using a standard to see whether there's going to be a response. So for papillary, all of these different things work in individual patients, but I can't tell you what to give your next papillary patient.
Right. Finally, let me ask you about urothelial cancer. This has been a discouraging area for some time. We have gemcitabine and cisplatin and primarily chemotherapy. You presented some data with eribulin at this year's meeting. What's going on in urothelial cancer, what Rob Dreiser refers to as the low-hanging fruit, because there's just not a lot that's currently available?
So we should be able to make progress in this area. We're inhibited at the moment because the benefits we've seen systemically have been with cisplatin, and the patient has to withstand surgery if they have localized disease or combination radiation, and we're getting better at that. We have some kind of sort of treatments for patients that can't tolerate surgery. But for the patient with metastatic disease, we have a bizarre, almost oxymoronic juxtaposition of cisplatin, which produces renal impairment, and where you can't give it to patients with renal impairment, to patients that tend to have renal impairment either because they've got an obstructed urinary tract, or because they've lost one kidney to surgery, or because we give them cisplatin and induced some renal impairment. So that's actually a big problem. So we've been looking to develop second-line agents, and also agents that can be given to patients with significant renal impairment.
Right.
So some years ago, a study was done internationally with a drug called vinflunine, which is a vinca alkaloid, and the trial technically was negative for overall survival, but they built in a multivariate analysis step, which was accepted by the FDA. This is for second-line, accepted by the EMEA, so in Europe, but did not look like it was going to be accepted by the FDA. So they have a second-line drug in Europe that can be given, and there's probably a standard of care there. After that, there's no standard of care, and in the United States, there's no standard of care after first-line cisplatin-based therapy. We developed eribulin as a first-in-human concept through the NCI. It was discovered as a derivative from halocondrin B, which is from the toxin of the black Pacific sea sponge. And this was found by the NCI of Canada in an exploration looking for active agents almost 30 years ago. And so that derivative, the analogue, became eribulin. And it's very active in a lot of cancers, and we found this in the first of human study that it did have activity against urothelial cancer, and most of the patients we put on that study have had 3 or 4 lines of treatment. Subsequently, it's been developed in breast cancer. The EMBRACE study showed a significant overall survival advantage to patients that had had 2 to 5 lines of therapy with metastatic breast, and so it's licensed internationally. In urothelial cancer, we've been moving it forward, and the NCI worked with us on initially 2 concepts. They wanted us to give it first line to patients that were not cisplatin candidates, and they wanted us to work it up as an agent for patients with renal impairment. Well, in summary, we can give it to patients with a creatinine clearance down to 20 at full dose, and it's effective. And also it had very significant activity in the first line. What I presented here was where we think we're going to do a phase 3 study, which is second or third line. And I presented data on patients that have not been exposed to a tubulin in the past. And so that's a taxane, like paclitaxel, docetaxel, or a vinca like vinblastine in MVAC. And it actually showed very significant activity with a progression-free survival of 4 months, overall survival of 10.4 months.
That's pretty good.
So we think that's interesting. Dr. Bellman reviewed it. He developed vinflunine and made the point that the numbers look better than that drug. There's nothing like a phase 3 study to sort that out, and we're planning on that. So we may have that, nab-paclitaxel, vinflunine, and some other things that we can give to our patients who have lousy renal function and poor performance status with urothelial cancer.
Very good. The first encouraging news in urothelial cancer in a while.
We haven't seen the summer yet, but we can plan on one maybe in a few years.
Very good, very good. David, thank you so much. It's always great to have an opportunity to chat with you about GU cancers, and I hope we can do it again soon.
I'll look forward to it, Jim.
Thank
you very much.
And thanks to all of you for watching this final segment from the 2013 combined meeting of Echo, ESMO, and ESTRO from Amsterdam. We look forward to visiting with you again, and we hope you will check all of the best of the day presentations from this year's meeting. Thanks again.